So PCN's a relatively new concept, about just over a year and a half old now, and it's a new way of working across boundaries in primary care so that GP practices can start to work together on larger scales to help build more efficient services and services that are better for patients, but also, and vitally, not just within GP practices, but GP practices reaching out and working with partner organisations they already work with, but organisations who are already involved in health and social well-being of the patients in new ways, so that we can work by working in new ways. We can be efficient, we can be better, we can solve problems more quickly and in a more holistic way. The patients will benefit because when they have a problem, that problem is, first of all, more likely to be noticed by the various systems involved in their care, or if the patient highlights the problem themselves, it will be very quickly directed to the people who are most likely to be able to solve it. Or if it's a complex problem, it'll be directed to a team of people who are meeting in a way they don't meet at the moment, to be able to solve the problems in a joined up way across the traditional care boundaries. So patients should notice a more responsive service. They should notice a service that solves their problems better because it's being dealt with by the people with the right skills at the right time, first off. One of the central motivations we believe for PCN formation is a way of protecting the model of healthcare being in the heart of the community as it is at the moment through general practice. So along with the PCNs is coming a whole new range of healthcare professionals, such as social prescribers. We're going to see physiotherapists as the first point of contact in primary care. We're going to see mental health workers as the first point of contact in primary care. There are already care coordinators who coordinate people who need care from different types of provider all the time. And then there's the traditional people that we work with already, district nurses, dentists, opticians, optometrists, community pharmacists. I hesitate to do a list because the list is essentially endless and I don't want to leave anybody out. But so working together with those people and making those people work together more effectively, plus the additional new roles, which are being formed and may go in many different directions at the moment. So a clinical director is, at the moment, largely the clinical directors through the country are GPs, although that's not a requirement. There are clinical directors who are nurses and come from other professions. And different primary care networks will set up their clinical director workforce in a different way. The way we've set it up in Nottingham West is we're divided into 3 neighbourhoods. That is Eastwood and Kimberley in the north, Stapleford in the middle, and Beeston, Bramcote and Chilwell in the south. So each of those neighbourhoods has a clinical director directly responsible for the primary care network delivery in their neighbourhoods. And then I'm the 4th clinical director without a neighbourhood to look after. And my role is to coordinate the work of the other clinical directors and the rest of the primary care network to make sure that all the innovations and projects that we are undertaking meet the timelines required and meet the deadlines. To be a public-facing side of the clinical directorship, to make sure that the engagement and this process of engaging wider organisations is definitely within my portfolio, and then taking the main responsibility. So it's my signature that goes on the dotted line when it's needed as well. So it's an interesting role, but it is very much embedded in a team, and a lot of it is about trying to build relationships and making relationships work in a way that they may not be working at the moment. And then just overseeing generally the work of the delivery of what's needed. If we don't have community involvement at that level, then the primary care network experiment will fail because it will just be another reorganisation of the health service. And the health service has been reorganised every few years since I joined it too long ago to think about. But this is the first real opportunity where there is a significant amount of genuine new funding and new structure that if we can work better with partners who are already providing care to the same people with the same problems as we are, then the level of care that the patients will get will be increased, because it will cover all aspects of their lives, not just individual bits, depending on the training of the person they happen to be sitting in front of at the time. We've got until March 2024 because it's a 5-year plan, and if it hasn't worked at the end of that time, like every other health service restructuring, it'll be mothballed and something new will come along. But if it is working by the end of March 2024, it'll be built on. And that's really what I'm very passionate about, making sure right at the start we make sure that no politician in their right mind would get rid of it in March 2024, because it'll be too good.